Good morning, everyone, and welcome to our Regional Geriatric Rounds webinar. My name is Stephanie Conrad. I am part of the Regional Geriatric Program of Eastern Ontario team, and I will be hosting today's session. We would like to advise everyone that today will be our last Regional Geriatric Rounds until September 2020. Please also be advised that this event is being recorded, and at this time, all participants are on listening mode only. Should you have any questions or require assistance during the presentation, please open the chat feature located at the bottom of your Zoom screen. At today's Regional Geriatric Rounds, Dr. Nathan Stahl will be presenting on Look at All the Lonely People, Social Isolation and Loneliness in Older Adults. Dr. Nathan Stahl received his medical degree from Western University, completed his residency in internal medicine and fellowship training in geriatric medicine at the University of Toronto. He is currently a research fellow at Women's College Research Institute at the Women's College Hospital and is completing a PhD in clinical epidemiology and healthcare research at the Institute of Health Policy Management and Evaluation at the University of Toronto. His doctoral research uses large administrative databases to study the population health impact of caregiving for dementia. His other research interests include drug safety for older adults, sex and gender-based determinants of aging, and healthcare utilization among persons with dementia. His research is supported by the University of Toronto Department of Medicine's Elliott Phillipson Clinician Scientist Training Program and Vanier Canada Graduate Scholarship. Dr. Stahl has been a staff geriatrician at the Sinai Health System since 2017, where he attends on the inpatient geriatric medicine consultation service and on the internal medicine clinical teaching units. His clinical work focuses on acute care geriatrics.
Thanks very much. Good morning, and I appreciate everyone who's logged in during these somewhat uncertain times. So we will try and for the next hour to try and sort of get our mind out of COVID for a second, but I will touch on it and speak a little bit about a topic that is critically important in older adults, which is social isolation and loneliness. So as Stephanie highlighted, my talk is entitled Look at All the Lonely People. And you'll note that that's comes from a Beatles lyric, which we'll get to. Stephanie introduced all my affiliations. I wanted to highlight that I have no conflict of interest to disclose. And I'm fortunate to receive financial support from several institutions, most notably the Department of Medicine at the University of Toronto, their Elliott Phillipson Clinician Scientist Training Program. So before we start, I just wanted to talk a little bit about a few words about language. So we will, in my talk, I will use neutral terms like older adults and older Canadians and avoid terms that possibly connote negative stereotypes like seniors and elders or elderly. And I will avoid catastrophic language or catastrophic terms to describe demographic changes like tidal wave, rising tide, or silver tsunami. But when we also think about language, and I'll talk about that as well, I'll also talk about caregivers as well, and the term that I'll use will be family caregiving, as opposed to informal caregivers, which may also connote negative stereotypes. So the outline of today's talk is that I will define loneliness and social isolation, which are often conflated. We'll talk a bit about the epidemiology and risk factors of these. I'll review the morbidity and mortality associated with social isolation and loneliness, and we will discuss practical approaches to assessment and management in clinical practice, and explore some of what the structural level approaches to preventing and mitigating social isolation and loneliness among older adults might be. Some of that is actually acutely relevant in the setting of our COVID-19 pandemic, where we are asking older adults to maintain as much social distancing as possible, and also imposing some restrictions on access to visiting them. So this is a statue in the United Kingdom of Eleanor Rigby, and you'll know the famous line from her, from the song, the Beatles song, Look at All the Lonely People. And some have described the epidemic of loneliness, which I will highlight as our Eleanor Rigby problem in society. and a problem that disproportionately affects older adults. So let's define loneliness and social isolation. So social isolation is actually the objective physical separation from others. So one may have a lack in quantity and quality of social contacts, as happens, unfortunately, sometimes with aging, is that the size of one's social network and the frequency of contacts with that network shrinks. Um, this can lead to loneliness, but importantly, it's distinct from loneliness. Loneliness, on the other hand, is a subjective state. It's the distress, the emotional feeling that results from discrepancies between what an individual prefers in terms of their social contacts and their actual social relations. So it's the quote unquote psychological embodiment of social isolation. So when we think about isolation, it's that physical or that objective lack of social contacts. But the loneliness is a subjective state. So you don't actually have to be socially isolated to be lonely. So the common example that's often painted is one can feel lonely in a crowd. And as I'll show you from some data, particularly on older adults, people can live with somebody else or even be married and still feel lonely. But certainly loneliness can also lead to social isolation. So they're mutually exclusive, but they can lead to the other state, loneliness and social isolation. I find the late Robin Williams quote in order to distinguish between social isolation and loneliness as quite illuminating. So he said, "I used to think that the worst thing in life was to end up alone, which would be social isolation. It's not. The worst thing in life is to end up with people who make you feel alone." And that's really the sort of embodiment of what loneliness is. So let's look a little bit about the epidemiology and risk factors for loneliness and social isolation. So one thing we have to know when we're talking about this, and this is part of the challenge when we try and highlight the issue to healthcare policymakers and talk about this as a health issue, is that the prevalence estimates are challenged by the lack of routine and systematic assessments. And we often use proxies like demographic characteristics, so census data, as indicators of social isolation, so the number of individuals who might be living alone. And then data from nationally representative samples are used to provide estimates beyond the basic demographics we might collect. So if we simply look at just the prevalence of individuals living alone, and this is data from Statistics Canada using 2016 census data, on the shaded area is 1981, and you'll see and you'll see the number of individuals on the left-hand side who are men and on the right-hand side who are women who live alone. So predictably, people live alone in their 20s to the 40s, and then there's a larger bulge later in life, particularly for women as their partners or their husbands may die, and so much more women live alone or are socially isolated. The blue line, so that was 1981, is what we're seeing now in 2016. So certainly some of this is related to population growth, but some of this is also, you'll see particularly for men, we're experiencing as sort of life expectancies between men and women approach each other, significant levels of social isolation, not only among women, but among men. And you'll see that these are really the highest number of individuals living alone are those who are in the older adult range. So the individuals are 65 plus, and certainly disproportionately for the population, or the number of or the population for that age group. What we do know is that about a quarter of older Canadians live alone, and again, this is showing that data in a number of in a different way, looking specifically at the proportion who are living alone by age. And so, if you look at the right-hand side of that graph, the proportion of people who are 80 or 85 who are living alone, and women are in the lighter blue lines, and men are in the darker blue lines. You'll notice that it's a substantial proportion in those age groups that are actually living alone, approaching about half. If you look at the United States in terms of the prevalence of living alone, very similar data. This is for 65 and older, but from 2018 from the U.S. Census Bureau. Um, and in terms of individuals who are the age of 65 who are living alone, that's in the sort of candy striping of the red and white. Only 21% of men, but you'll see that 34% of women are actually living alone. And that's a common theme, that men are more likely to live with others than women are, particularly when they're older adults. What's the prevalence of social isolation? So we're able to scratch at this a bit from some of the, we have some gaps in this because of the way the census was cut during some of the years during the Harper government, but from the Canadian Community Health Survey, we know that about 16% of older Canadians feel isolated from others often or some of the time. You know, some really sobering and heartbreaking statistics: more than 8% have someone to receive advice about a crisis none or little of the time. You know, 1 in 20 have someone to listen to them none or little of the time. About 6% reported never or not often participating in activities with family and friends, and about 20% reported feeling excluded often or some of the time. So you know, there's certainly, in terms of social isolation, some real sort of sobering data here. What about the prevalence of loneliness? Well, sort of the best national data we have is starting to emerge from the Canadian Longitudinal Study on Aging. This is a large national long-term study of individuals when they're recruited between the age of 45 and 85. And you'll see when you look at loneliness some of the time, and these are the percentages, when you start to look particularly in the 75 plus, about a third of women and 1 in 5 men feel lonely at least some of the time. Interestingly, and I touched on this earlier, let's just draw your attention to the married row here. Even in the 75 plus, about 1 in 5 women who are married feel lonely. And when I've given this before, the women in the audience will laugh and say that should be no surprise to you, whereas only about 12% of men in marriages feel lonely. So there's the discrepancy about the prevalence of loneliness even when people are married. But that's a sort of important thing to highlight, that you know, individuals who are married, we shouldn't necessarily assume that they're not lonely. And certainly even, and I touched on this before, when you look at the bottom row here with living arrangement, those who are living with at least one other person, if we look again in the 75 plus age group, well, 1 in 5 women, even though they're living with somebody else, still feel lonely. And very similarly, about 15% of men, even though they're living with somebody else, they're not socially isolated, still feel lonely. When we look in Europe, this is, let's just focus on the dark curve here. This is the prevalence of loneliness with age. This dark curve is actually none of the time. So the other way of looking at this is that so individuals who are younger and older, those are the individuals who are who tend to be lonelier, because this is sort of the inverse, that they're lonely none or almost none of the time. So it tends to be a bimodal sort of distribution in terms of loneliness, where our younger individuals, and there are some reasons for that, which are outside the scope of this talk, but relate to sort of the digital revolution. And even though we're more electronically connected, we're actually more disconnected than we ever have been in human history. And then certainly the reasons for being lonely, some of them touch on a digital revolution that has left older adults behind, but there are many other reasons why older adults also feel lonely. But just to point out that this isn't exclusively an issue for older adults, and it tends to be bimodal, again, with younger people. And by younger people, I mean those who are sort of in the 19 to 30 range, even teenage years, and 80 or older. What are the risk factors? So like many things in geriatrics, they're multifactorial, but older adults who are at risk, age and gender, as I've spoken about, so particularly females, older age. There are ethnicity, particularly for new immigrants, particularly for non-English speaking immigrants who may come to this country at an older age. Sexual and gender identity are another sort of intersecting sort of group of individuals, those who may be in rural areas, those who have other functional disabilities, those who are experiencing life transitions, and then those who may already at baseline have a lack of social relationships. So as I've highlighted in some of that, there are specific groups of older adults who are at risk. Those who have physical and mental health issues, those who are family and friend caregivers, which is another area of interest of mine. So they may be so devoted to the care recipient that they themselves may actually socially isolate themselves due to the sort of significant burden of unpaid caregiving. Those who are low income, certainly indigenous populations, newcomers or immigrants who have language proficiency issues, and then members of the LGBTQ2S plus community where, particularly for older adults, they face unique challenges. So now that we've looked sort of at the definition, some of the epidemiology and risk factors, let's review what the morbidity and mortality is. This is some of the stuff that does actually make the headlines. So this is an often cited review that's a scoping review of 128 items from 15 countries. And what's important to note is that the evidence is largely US focused. And that's actually interesting because some of the world leaders in this have actually been from the United Kingdom. Loneliness is much more researched than social isolation. The causal links and mechanisms, which I think is troubling to people who are trying to perceive this now as a sort of syndrome of importance to health, are difficult to demonstrate. And then there's a positive research focusing on those at-risk subgroups that I highlighted a couple slides ago. When they look at the outcomes for loneliness and social isolation, the most frequently studied outcomes are depression, cardiovascular health, certainly some studies on quality of life and well-being. But you'll see there's a whole range of other studies that have looked at things like cognitive function, mental health, dementia. Again, this is related to older adults that lead to sort of negative outcomes across a whole range of both physical and mental health conditions. This is the one that has really made headlines, which is, so Julian Holt-Lundstadt at Brigham Young University is sort of a world expert in loneliness, and they did a meta-analysis of 148 studies. Again, you'll see that most come from North America, but you will see that even though they didn't restrict to older adults, the initial mean age in these studies was 63.9 years, and they followed individuals for 7.5 years. What they did find, and this is something the Surgeon General in the United States has highlighted, was that if you look at the effect of smoking 15 cigarettes a day, and then you look at those who have high versus low social supports, so the individual, and this is looking again, some of these figures are in the sort of backwards way. So they looked at smoking less than 15 cigarettes a day, and then having high versus social low social support. Having a robust social network is actually much more protective against all-cause mortality as compared to smoking cigarettes a day. And so what's been highlighted of this is, sort of turned around that individuals who are lonely, it's more harmful to the overall mortality than smoking 15 cigarettes a day, and certainly more potent than things like alcohol consumption, flu vaccination, physical activity, being obese. So starting to look at loneliness as a real risk factor for health and with hard outcomes like mortality. This is a study from the Archives of Internal Medicine, which is now JAMA Internal Medicine by Ken Kavinsky and colleagues at UCSF. They looked at a longitudinal nationally represented cohort of 1,600 older Americans. So the prevalence of loneliness, which sort of mirrors what I showed you with Canadian data, a little bit higher. You remember the Canadian longitudinal study of aging was in about the 20% range. The prevalence of loneliness was 43%. Interestingly, and to my point again, about 62.5% were married who endorsed being lonely. They looked at, down here in the bottom right, what's the risk ratio in terms of having any of these outcomes if you're lonely. And what they did find was, so the only one that didn't meet statistical significance when they adjusted for everything else was the mobility outcome. But if you're lonely, you're more likely to have functional decline, you're more likely to have difficulty with climbing, and most notably, you have a adjusted risk ratio of 1.45 of having death when you are lonely. And then what about risk of dementia? Something that's also come into light in recent months, certainly in the news. So this is data from the Health and Retirement Study in the United States. They looked at cognitive status at baseline and every 2 years over 10 years, and the mean age of participant was 67.3 years, and they looked at risk of dementia. And what they found was that loneliness was associated with a 40% increased risk of dementia. So certainly there's, and we could criticize many of these studies in terms of bias and ascertainment of outcomes and how loneliness and socialization was measured. But there's enough sort of accumulating data that I would argue that people are starting to take this seriously. And certainly it affects many different health outcomes, whether it's hard outcomes like mortality or some of the ones I showed you in terms of mental health with depression, and relevant to older adults, cognitive well-being. And so I think many of us, and certainly more recent data from the Lancet in terms of the Commission on the Prevention of Dementia have started to recognize remaining socially active and well-connected as something that's protective for cognitive health. And more data, if I haven't convinced you, this is looking at frailty. They measured frailty by the Fried phenotype, and they looked at the risk of social isolation and loneliness for the progression of frailty. And what they found was that when you had higher levels of loneliness, you were more likely to become pre-frail or frail in a longitudinal cohort that they looked at, and their follow-up was at about 4 years. This is sort of a nice, I think, conceptualization published in Heart a few years ago now already, in terms of how these things may interact. So on the left-hand side, or how we lead to these sort of quote-unquote hard outcomes like morbidity and mortality. So social connection, there's the sort of quantitative and objective, which I've pointed out to you before, is social isolation. There's the qualitative and subjective, which is loneliness. This leads to a few things. One is that when these things happen, you're less likely to engage in physical activity, good nutrition, practice good sleep habits. You may be more likely to engage in risk-taking behaviors, to smoke. There is the psychological stress that occurs with that. And then there's issues where one is lonely. They're less likely to adhere to medical recommendations, to follow diet recommendations, or to execute lifestyle change. Overall, and they've studied this in individuals, this leads to biomarkers that we see that get upregulated in stress conditions. There's worsening of blood pressure. There are all sorts of hormonal perturbations. And overall, this leads to worsening or acceleration of coronary heart disease, stroke, diabetes, and then we pick up things like all-cause mortality. So sort of thinking about how these things may lead to the downstream health effects that I've talked about. So now that we've reviewed sort of the loneliness and social isolation, some of the epidemiology and risk factors, what some of the commonly reported and best reported morbidity and mortality associated with social isolation and loneliness, let's discuss some practical approaches to assessment and management in clinical practice. So this is Dr. Vivek Murthy. He was the Surgeon General under Barack Obama, who's shaking his hand here on the right with the portrait of Lincoln in the background, and of course was fired by Donald Trump swiftly when he came into office. But Vivek Murthy, who was the Surgeon General from 2014 to 2017, said that and he really took this on as an issue, that during my years caring for patients, the most common pathology I saw was not heart disease or diabetes, it was loneliness. And this has led to sort of the epidemic of loneliness, and that's the only time I'll sort of use this catastrophizing language that I highlighted at the beginning of the talk that I would not. So what are the challenges when we're dealing with an issue like loneliness and social isolation? Well, like many things that we've had to convince people to do in geriatrics, its evaluation hasn't been integrated into clinical care. There's really not a uniform way of evaluating and documenting it as part of a review of the social determinants of health. I would argue that overwhelmingly medical communities have not placed the emphasis on loneliness and social isolation, even though we've had some of the evidence about the potency of it as a risk factor for some time. And then I think practitioners overall are, when they encounter lonely and socially isolated patients, feel somewhat helpless about what to do with these individuals, despite some promising interventions and solutions. So assessment. We're seeing these patients come into our clinics. We may be encountering them in the inpatient settings. We may be seeing them in the community or in long-term care settings or retirement homes. I think the first thing, which I hope I've convinced you about, is don't assume you know who is or who is not lonely. I showed you that in the American study, about 60% of individuals who were married endorsed feeling lonely, that many people who live with somebody else also experience loneliness despite not being socially isolated. One of the important things is to discuss and ask about loneliness and social isolation. Doctors should start thinking about them as important upstream factors included that influence health and well-being. And then there are some validated screening instruments, one of them which I'll show you, which one can sort of start thinking about doing in clinical practice. So this is the UCLA scale. It's just 3 questions, and scores with 6 to 9 are considered lonely. So how often do you feel that you lack companionship? How often do you feel left out? And how often do you feel isolated from one another? So again, it's the feeling when we're talking about loneliness. What about management? Unsurprisingly, there's very unlikely ever to be a one-size-fits-all solution for something like loneliness or social isolation. And so the interventions need to be tailored based upon the mechanism of the problem. There are individual level interventions, and there are also sort of structural and societal level interventions, which I'll highlight. Overall, there is robust evidence for the effectiveness of these interventions, there's a lack of robust evidence, which is often the criticism for individuals when they're proposing these things or asking for government funding or trying to scale up their program. And then most of the studies are weakly designed because of the challenges of what we're doing. So they might be a single group, they may be a pre and post, and they're often non-randomized. So, and when someone's putting this forward and they're making arguments this is something as important or has a mortality risk that confers a higher mortality risk of something like diabetes or heart disease, but they're comparing it against cardiovascular trials, which are much more, I would argue, easy to carry out in some sense and have a much more sort of homogeneous outcome. It can be challenging to persuade individuals. So what are the individual level strategies? So a lot of the best research and the best sort of programming, I would argue, comes from the United Kingdom. So one of them is just increasing opportunities for social support and social contact. So a social recreation intervention. So that might be things like providing transportation for individuals who are no longer able to get to the social contact they may want to engage in. One is enhancing social supports, so developing mentoring programs, buddy care programs, having conference calls. Some of that, and again, I'll speak a little bit to this in the end, is just so incredibly relevant in the setting of this COVID-19 pandemic. So some of this is improving social skills. So some individuals may have already had sort of, before they became socially isolated and before they experienced loneliness, may have had premorbid sort of poor social skills. So this is speaking on the phone with individuals, giving and receiving compliments, and enhancing nonverbal communication skills. And the last, and I'm sure we've all experienced this, is the fact that many individuals sort of get stuck in this rut where they sort of perseverate about their lack of social context, how lonely they are, and some of this is addressing their maladaptive social cognition with cognitive behavioral therapy. Those sort of 4-pronged approach is the sort of best evidence of what exists in the literature to date in terms of the individual level interventions to improve loneliness and social isolation. I would, again, keep in mind increasing opportunities for social contact and enhancing social support, particularly during this COVID-19 pandemic. these are some of they did a scoping review of what the interventions to address social connectedness and loneliness for older adults, what exists in the literature. The majority involve one-to-one personal contact, activity, and discussion groups. Some of them have looked at things like animal contact, skills courses, models of care, reminiscence groups, and I think things like public broadcast are also interventions that have been looked at in some jurisdictions to make people feel more connected when they're older adults. Social prescribing. I'm sure many of you have started to hear about this. What is social prescribing? Social prescribing is defined by the Alliance for Healthier Communities as a, quote, a deliberate and structured way of referring clients from clinical practice to non-clinical supports when appropriate, with the goals of improving their overall health and well-being and decreasing the use of the healthcare system for non-clinical needs. So as a clinician, often, when we see someone has hypertension or high blood pressure, I think most of us are very comfortable saying, well, okay, well, if appropriate, we're going to put this person on an antihypertensive treatment. But when we identify someone who's lonely or socially isolated, even if we've identified them, we feel somewhat lost, or we struggle to think about what might be the way that I would be able to prescribe them something to help them. So this is sort of a nice schematic, again, from the Alliance for Healthier Communities, that the primary care clinician makes the social prescription. So after fulsome discussion, and most of these models work with what's called a link worker or a navigator in the community that's aware of what the appropriate resources or supports. So again, coming back to that four-pronged approach, if the issue is opportunities for social contact, the link worker might identify what some appropriate programs would be, and then the link worker would connect them to these social and community supports. And this would be sort of one model of how social prescribing would work. This is from a jurisdiction in the United Kingdom, and you'll see that really social prescribing can be quite diverse. So whether it's volunteering, whether it's sports clubs, whether it's educational learning, schools, participating in charity, getting into community groups, really social prescribing really depends. Again, it's a sort of multifactorial intervention, often depending on the individual needs of the person and what we think is driving the social isolation and loneliness. This is starting to happen, really thankfully, in Ontario. So unfortunately, the ROM is now closed during COVID-19. But what the ROM started doing, they have a program called ROMCAN. It's a social prescription initiative that they launched. And basically, a clinician, they had a pilot program. A clinician could write a prescription for them to visit the ROM, and they will provide a free access to the ROM. It's an opportunity for people to benefit from what they call an uplifting experience of engaging with art and culture. So we're starting to see this also at the Art Gallery of Ontario. This is just in Toronto alone, but certainly different jurisdictions across Ontario and Canada. What I think is really, really critical in this, and I really love this quote, and I often come back to it, it's just as a doctor's prescription can only improve health if the patient has access to a well-stocked pharmacy, so social prescribing schemes depend on a well-stocked community. So this is critical, right? If we don't have resources and community that we could draw from, we can prescribe things, but there may be nothing to link that person to. So we need to think a little bit about the communities and how we can have communities that are sort of, so to speak, well stocked, just as a pharmacy we hope is well stocked with the medications we may need. So the final thing, and then I'd like to leave some time for questions and discussion, is to explore what some of the structural level approaches to preventing and mitigating social isolation and loneliness among older adults might be. So this is a report from the WHO. They have developed, this was already from 2007, about what age-friendly communities look like. And they've touched on several different aspects of the community, whether this is transportation. So how do we make public transportation more age-friendly? Housing, social participation, having respect and social inclusion of older adults. How do we encourage them to have civic participation, remain gainfully employed if they're interested? How do we communicate and provide information to older adults so that it's age-friendly? What are the community support and health services, and how do we have outdoor spaces and buildings that are age-friendly? So just coming back to that, so New York City is actually a leader in terms of this, and have been highlighted as sort of an age-friendly city. So things like transportation, you know, they've considered things like ride-sharing services that maybe lower cost or no cost for older adults. How do they design parks that have benches at the appropriate intervals so that older adults can rest when they become tired? The signage that we use in terms of wayfinding, the housing that we have individuals in who are older adults, these sorts of things are carefully considered by age-friendly cities. And I think increasingly we are trying to do this in other cities, particularly in Canada. I think another sort of structural level intervention, and we're seeing this a bit actually in the COVID-19 epidemic or pandemic, is that raising public awareness. So the United Kingdom is a world leader in terms of loneliness and social isolation. Famously, we'll see what happens with Boris Johnson, but under Theresa May, they actually appointed a minister for loneliness, recognizing the sort of incredibly important societal and health problem that loneliness is, and actually had a commission on loneliness in honor of one of the MPs who was actually tragically murdered, Joe Cox, who was the one who sort of brought this forward as an issue of great importance. And they have a whole campaign to end loneliness, which has some outstanding resources that have actually, again, sort of messaged this around COVID-19 in light of all the social distancing we are seeing. This is a sort of nice sort of slide that sort of brings it together, which is that I think overall we need to recognize social isolation and loneliness as public health priorities. It needs to be consistently recognized as a major determinant of health. And then what do we need to do? So there are society level and policy level interventions. So you know, funding for the development and testing of social relationship interventions, recommendations. There's a community sort of organizational approaches, and then all the way down to the relationship and individual approaches, which many of these things overlap, but things like incorporating health outcome measures and relationship intervention studies, looking at building the evidence for social prescribing and social relationship interventions, community-based participatory research in relationship science, things that have been sort of traditionally, I would say, ignored or not prioritized or valued in the same way that we may value other types of science, or things that have been sort of, when this has been tried to be put forward in terms of medical science or health services research, have been told that this is really a social sciences or behavioral studies. These are the ways we need to sort of think about changing the way loneliness and social isolation are being considered, and I think they are. And really, you know, public health, we're talking about it a lot these days, but really we need to think about it a little bit like a public health approach. So there's primary prevention, which is reducing the likelihood that people become isolated or lonely in the first place. So encouraging people, particularly as they enter one of those at-risk age groups, so whether that's younger, but again, here we're talking about older individuals, to build robust social networks, to learn coping skills and emotional self-regulation. And I think what's important, like many things, is that complete prevention or eradication is an unreasonable goal. Like many things in life, some of the hardships that we endure, whether it's emotional or psychological, can actually be character building or build resilience. So we're not asking people to completely prevent or eradicate loneliness or social isolation here, but it's to recognize that this is a problem, and how can we encourage people, again, to build more robust social support networks. Secondary prevention. So when we see that it's already occurring, it's intervening in the early stages of isolation and loneliness before they become severe or chronic. So when we know someone is going through a critical life event like bereavement or retirement, transitions that we know are challenging for individuals, how can we intervene to prevent that from getting worse? And then tertiary prevention is when loneliness and social isolation have already occurred, how can we minimize the negative impact through psychological self-care, efforts to improve their physical and mental health so that they don't sustain those that morbidity and mortality we highlighted. And I think a public health approach for something like loneliness is actually quite relevant here. So to conclude, and I will have left, I guess, about 15 to 20 minutes to have questions here. I just want to highlight or hammer home some of the main points, and then I'll have a couple comments about COVID-19, which is that social isolation and loneliness, I've showed you, are distinct concepts. Social isolation is that objective state of having few contacts, whereas loneliness is the perceived state of social isolation, that emotional distress that occurs when someone has a discrepancy between their actual and preferred number of social contacts. I've showed you based on census data that many older adults live alone, many are socially isolated, and even those who don't live alone or who are in marriage, many feel lonely. Best data we have from Canada is about the 20% range. The United States, some cohorts have showed 40% range. We've talked about risk factors being multifactorial, with age and gender being major contributors, but certainly family caregivers, individuals who have intersecting forms of marginalization in our society. So individuals who are older adults who are lonely, and also from groups like our LGBTQ2S+ communities, new immigrants, those with limited English proficiency, our indigenous populations. These populations are at increased risk. I hope I've convinced you that loneliness and social isolation can be as harmful as other well-established risk factors for mortality, for mortality, and they're linked to significant morbidity. So again, loneliness has been shown to be comparable to smoking 15, or worse than smoking 15 cigarettes a day, worse than things like diabetes and heart disease. And then overall, the evaluation and management hasn't been integrated into clinical care into the way that I think it ought to be. We have several validated screening instruments. I've shown you that UCLA scale, which is sort of a 3-question screening instrument, and that there are individual level interventions to sort of improve social contact or opportunities for social contact. One of those is social prescribing, which is again sort of applying that traditional paradigm of prescribing a medication that a practitioner might do, but in this case, prescribing an intervention to improve or increase someone's social contact. I think overall, what's critical is that structural interventions are essential as enablers. So whether that's building age-friendly cities, whether that's developing research partnerships to scale up social relationship interventions, and whether that's all of us being more aware that this is a huge sort of public health problem. And I think the United Kingdom, again, has been leaders in terms of that with the establishment of a Minister for Loneliness. And then finally, we must recognize that this is a public health priority. The last thing I was going to say and there's been some really fantastic articles written on this. We know, and I'm acutely aware today that on March 16th, that people's minds are far probably elsewhere from this issue in terms of the COVID-19 pandemic. And appropriately so. One of the things that we are being asked, and again, very appropriately so, is to maintain social distancing to help, quote unquote, flatten the curve of the COVID-19 pandemic. One of the things to recognize here is, as we know, that COVID-19, the data that has come out of China has shown that older adults are the ones who not only, I mean, everyone can get infected with this, but are the ones that have had the highest mortality. And we're seeing mortality in older adults, 80 plus, of like 15% in terms of case fatality rate, in the 10% range for people 70 plus. We're asking older adults themselves to be socially isolated. We're restricting access to long-term care and retirement homes. And when we as a society increase increasingly promote and further social distancing, there's going to be, you know, understandable and predictable downstream consequences in terms of exacerbating loneliness and social isolation. What we're not saying is that we should avoid these measures, but I think to many extent what we need to do, and what I think we ought to be doing more for individuals who can and able, is how can we change the way we interact and visit with our older adults during this time that is really scary for them. So, you know, probably it was last week, but even now it's a good time to invest in an iPad or a piece of equipment where one can FaceTime or have video conferencing or chat with them. How can we make older adults feel that they're still connected in this extremely scary time when they're already socially isolated, when visitations again to long-term care and retirement homes are being restricted? And how can we, when they've shut down all the social programming, still make them feel connected and not completely isolated from the scary world? And I think that's been somewhat lost, but some have appropriately raised it in the conversation of social distancing and the COVID-19 pandemic. So with that, I'd be happy to take any questions you may have. These are some useful resources. Again, particularly in the setting of this COVID-19 pandemic, the Campaign to End Loneliness has had some really useful resources in terms of how to check in with older adults, checking in on your neighbors, offering to do tasks, you know, even going to a grocery store for them is something that's not only overwhelming in the state of panic buying, but extraordinarily fearful or fear invoking for them. So some useful resources. And with that, I'd be happy to take any questions you may have.
I will take this opportunity. Thank you very much, Dr. Stahl, for your wonderful presentation in a very appropriate timing to our attendees and for the website for people to view at a later time. It was very enlightening, and your points at the end were great. There's still opportunities for people to connect and help with the loneliness and social isolation during social distancing. So thank you again very much for taking the time to present. We very much appreciate it.